Hi, how are you, everybody? Really thank you for joining us. This is the special keynote lecture session 2022 TCTAP, as a part two, transcatheter heart valve interventions. Today, I have I'm very happy to have Everhard Gruber, my old friend, as a co-moderator. Everhard will present the panelists and the first speaker, Marie-Leon. So please, Ewa.
Thank you very much, SJ. It's a great honor and great pleasure to be back again on this transcatheter heart valve intervention. And we are joined by an extremely important and esteemed faculty and panel. The lecturers will be introduced once they will give their lectures. I'd like to welcome the panelists. That's Lars Sondergaard, Saibal Kar, Jean Minan, Eric Finkelstein, and Tullio Palmerini from Italy. So without further ado, I think, Marty, you don't need any introduction, obviously. Really pleased to have you. And the floor is yours with your keynote lecture, Upstream Management of Aortic Stenosis. Marty?
Everhard, thank you very much. First, I want to thank S.J. Park. He's been a special friend for now several decades. So anytime I can ever help him with TC Asia Pacific, it's certainly an honor for me. I'm going to talk about a topic that has become more and more interesting and important that I think will be part of the future of how we manage aortic stenosis. These are my disclosures. So I'm going to try to explain what I call the conceptual framework of upstream management, touch on some issues of underdiagnosis and treatment of AS, introduce some new screening tools for AS, then focus on some of the preemptive earlier AVR strategies being applied, and then end in something atypical for an interventionalist to talk about pharmacotherapeutics for aortic valve disease. So this is the framework. We need to understand that aortic stenosis is a chronic, continuous disease. It is punctuated by clinical events, atrial fibrillation, cardiac symptoms, and also structural changes like LVH or pulmonary hypertension. I believe that the earlier management, both diagnosis and treatment, leads to optimal clinical outcomes. I also feel that delaying the progression of calcific AS with pharmacotherapy before the onset of symptoms or the need for AVR should be an aspirational goal for the future. And that clinical research efforts should shift from late-stage reactive AVR to early-stage preemptive AVR and other complementary therapy approaches, and that the availability of less invasive, low-risk transcatheter technologies combined with more durable heart valves, which is now a work in progress, coupled to enhance and easily accessible early diagnosis, is going to transform AS patient management in the future. So that is the concept that I'm trying to promote. You're all familiar with the Ross-Brownwald manuscript more than 50 years ago, which was the traditional thinking of aortic stenosis. This is one of the most recognizable figures in all of cardiology, showing the long latent period before symptoms begin. At that time, they didn't realize that aortic stenosis was a later stage disease and would be dominated by senile calcific aortic stenosis. But there are two fundamental fallacies. The first is that there are no important reversible or irreversible structural changes during this so-called latent period, which will negatively impact subsequent clinical outcomes. And second, that the onset of symptoms is discrete, easily identifiable, even in the elderly, and is inexorably linked to aortic stenosis severity. These two fallacies have impacted our thinking on how we manage patients. So we celebrated the 50th anniversary of that landmark natural history manuscript with Eugene Brownwald, the co-author, a few years ago. And we asked him, as far as he's concerned, what was the most important recent research in the area of aortic stenosis? And he pointed to this manuscript. It's a manuscript that we published in the European Heart Journal in 2017, talking about a new staging classification for AS. Philippe Ginneroux was the first author, where we divided AS, and these are patients that have severe aortic stenosis, into 5 different stages of cardiac damage. What was fascinating is that at the time of treatment, either surgical or transcatheter AVR, 80% of these patients already had significant cardiac damage, and much of it is irreversible. And if you look at 1-year mortality after AVR, it was very closely associated with the degree of cardiac damage. Now, that's severe aortic stenosis. What about moderate aortic stenosis? This is another study that was done with Jerome Bax in his database in Leiden in over 1,200 cases, a very similar analysis. And even in moderate AS, many of whom were completely asymptomatic, 60% had significant cardiac damage at the point of echo diagnosis of moderate aortic stenosis. And again, it predicted 5-year mortality and other combined endpoints. So this concept of upstream AS treatment suggests that the treatment dogma of only treating the severity of AS is not the correct approach. That we have 2 parallel processes with variable linkage, and to try to understand at what AS severity do adverse events occur is very difficult, and there's wide patient variability in AS afterload tolerance and the expression of adverse events. But yet the guidelines, the only class 1 recommendations, are all severe AS and generally with symptoms. Let me shift now to the concept of underdiagnosis and undertreatment of AS. These are old slides, but fascinating. This is 2015 from a large database looking at the number of surgeries done for aortic stenosis in the United States relative to age. And here we're including the number of TAVRs done in the same year. About the same number, slightly less, and clearly in older patients. But this is the number of patients with severe symptomatic AS in the United States. So clearly a very large population that was undiagnosed and untreated. This is from an 80 million person claims database, indicating that even recently, more than 60% of diagnosed severe symptomatic AS patients are untreated. And there are widespread racial, ethnic, socioeconomic disparities, which you're going to hear about later, which to a certain extent contributes to this lack of access and to the undertreatment, even if you correct and adjust for age and clinical comorbidities. So race bias is really an issue that we face. Now, at a time when we're seeing a massive global population growth in valvular heart disease due to an aging world population, where if you look at moderate or severe AS and MR, the incidence is going to be over 150 million people in 2040. You can see to manage this patient population is going to require completely new screening tools. This is something that we've become very interested in. These are data out of the Mayo Clinic. It was an interesting report a little over a year ago, looking at artificial intelligence from a surface 12-lead ECG that was able to, with pretty good sensitivity, specificity, and accuracy, diagnose moderate or severe aortic stenosis. We've replicated these data, but have looked not just at AS, but aortic regurgitation and mitral regurgitation. And you can see again that the area under the curve, the ROC curve, was strikingly good for AS, AR, and for MR, just looking at an EKG. This is from over 200,000 patients. And there are other machine learning techniques looking at echocardiograms that will identify distinct phenotypes of patients that are at higher risk and need to be treated sooner. So screening and profiling treatment is going to depend a lot on new techniques that allow us to be able to better profile patients and get them into the diagnostic and treatment queue. Now back to this concept of preemptive AVR or earlier AVR. There have been 2 surgical studies in severe asymptomatic aortic stenosis. They're small studies, one from Korea, as you can see here, 145 patients with a dramatic difference in the primary endpoint, which was follow-up mortality, comparing surgery versus conservative care. And then more recently, the AVATAR study that was from Europe, 9 centers, 7 European countries. Again, a small study, 157 patients, comparing conservative treatment to a surgical therapy, again, showing a major benefit of earlier treatment with surgery. Now, these are small, somewhat underpowered studies, but clearly this points to the idea that earlier or preemptive treatment in asymptomatic severe AS may be meaningful. About 2 years ago, we were all shocked with this large echo database that came out of Australia, looking at over 240,000 patients, which demonstrated that the long-term survival in untreated patients with moderate aortic stenosis was not very much different than severe aortic stenosis. Now, there may be many reasons for this. It could be the way the echocardiograms were done. There already may have been too much cardiac damage. The interventions may have been too late, but I think everyone was surprised by the very poor prognosis of moderate aortic stenosis. We've been involved for the past 5 years in a series of clinical trials that we would call earlier treatment scenarios. The early TAVR trial, which is severe asymptomatic aortic stenosis. This is a large study. Over 900 patients have been enrolled. Enrollment has been completed in December of 2021. We'll have results in the next few years. This is going to be a relatively definitive study with exercise demonstrated asymptomatic severe aortic stenosis comparing TAVR versus what we call active surveillance. And then the UNLOAD trial. And this is a study that was initially conceived by my good friend, Nicholas von Meegen. And this is looking at moderate AS in patients with reduced ejection fraction and heart failure. And this is still enrolling. Again, looking at active surveillance versus earlier AS treatment. Now, there's been a host of data over the past 5 years suggesting that there are at-risk predictors of patients who will do poorly if they have moderate aortic stenosis. And these are the 8 different variables that have been identified. Certainly symptomatic patients, low ejection fraction, although the cutoff is not 50, should be 60%. Atrial fibrillation, many echo parameters, elevated biomarkers, or an elevated calcium score. Any of these features confers a higher risk in moderate AS of doing poorly. Yet when we look at the guidelines for moderate AS, which is defined very clearly just by echo parameters, there's only one Class 2B recommendation, and that is for patients who are undergoing cardiac surgery for other indications. And the follow-up recommended is every 1 to 2 years. And these are at-risk patients. So that's led us to move from the UNLOAD trial to the PROGRESS trial, which is a larger study, as many as 750 patients, a 1-to-1 randomization of patients with moderate calcific AS who have at-risk features that suggest that their prognosis would be poor if they were simply treated with surveillance. So these patients have echo criteria for moderate AS, and they have either symptoms or evidence of cardiac damage or dysfunction by a variety of parameters that are listed here. And we've already begun to enroll. So when we look at this grid, which looks at the grade of valve severity on the left, and then the stage of cardiac damage across the top, I think you can see right now what we have approved is for severe AS in patients generally that have cardiac damage. With the combination of early TAVR and the PROGRESS trial, we think we're going to be penetrating some of these other categories of patients, which we think potentially could benefit from earlier treatment. And this is the first case that was done on the PROGRESS trial from Morristown. And you see Philippe Genereux, who's the principal investigator on the study, chairman of this trial. Should be a very interesting study. And finally, pharmacotherapeutics for aortic valve disease. To me, this is a fascinating area. The pathophysiology of aortic stenosis is fairly well known. There's an initiation phase, a propagation phase. There are all kinds of mediators of disease, including oxidative. All play a
Recording in
role
progress.
in the progression of aortic stenosis. But as of today, there are no known proven medical therapies to slow or prevent the progression of calcific aortic valve disease. In that same manuscript by Mark Dweck, he talked about future prospects of some very novel pharmacotherapeutic agents, PCSK9 inhibitors, interesting ways of doing things to be able to mitigate the development of calcific aortic stenosis. Now, this all began in the statin era, where we felt that aortic stenosis may simply be an extension of atherosclerotic coronary disease. And there were three major randomized trials, Saltire, SEAS, and Astronomer, all of which were negative. The modern thinking is that there are some new targets that could be very interesting. It's not going to be a one-drug-fits-all concept, and that we need to tailor therapy according to a variety of aortic valve and AS phenotypes. And maybe different kinds of patients would benefit from different agents. And this is going to be an area of active investigation as two new pharmacotherapeutic studies are beginning in the United States right now. Brian Lindman has done a great deal of work in this area, and it's been difficult to study these patients with aortic stenosis. And he's come up with some interesting ideas of how to look at potential therapeutic targets and accelerate how we can develop clinical trial study plans. And the last point I want to make is that not only do we want to prevent the progression of calcific AS, but to prevent and mitigate heart failure in patients with AS is a very realistic treatment goal. 50% of patients either die or have residual heart failure or poor quality of life at 1 year after TAVR. Heart failure is the most common admitting diagnosis during the first year after TAVR. And the residual risk from heart failure is primarily due to cardiac remodeling and irreversible injury. So it makes sense to consider before the onset of symptoms in severe AS to actually consider treating some of these patients that have myocardial alterations. So we've been looking at this, and many important heart failure drugs can be significant adjunctive medical therapy to protect the heart during progressive AS and augment the recovery after AVR. Things like RAS inhibition or Entresto or SGLT2 inhibitors. So this is going to be an active area of continued investigation as well. So medical therapy will be important, I believe, in the future, both to treat the valve and the myocardium. No medical therapies have been successful so far. We have a lot of novel insights into molecular targets. A multi-drug approach to precisely target disease stage and patient phenotype is the most promising. And we have to develop clinical trial processes to use a variety of new imaging techniques and some interesting surrogate endpoints as we study some of these pharmacologic approaches. So let me conclude simply by saying, if we look at this grid of all of the kinds of patients who had either severe valvular aortic stenosis on the basis of severity of stenosis, or various stages of cardiac damage, this multi-drug precision medical approach, I think, will play a role in the next decade as we go forward. And if we combine that with many of the other techniques that we are developing now for preemptive treatment, hopefully to be able to improve the durability of bioprosthetic valves, I think it's going to make a meaningful difference, especially if we combine that with better diagnostics and more generalized access to care. So, to conclude, the upstream management of AS. You can't solve upstream problems downstream, so we need to consider how we can manage these patients differently and treat AS as a continuous chronic disease. Thank you.
Thank you very much, Marty. Brilliant as always, giving us a lot of new ways of thinking about aortic stenosis, and we will probably have some time for discussion later on. And we would like to continue with Dr. Park on racial disparities in TAVR, similarities and differences. Dr. Wu, welcome, and the floor is yours.
Okay, thank you, Evhard. So today my topic is about racial disparity in TAVR and what is the similarity and what are different. This is my disclosure. Looking at the current available data of racial disparity and TAVR outcome difference, this is absolutely one of a highly debatable issue. So, and looking at the literature review, and this is published last year, and they are evaluated the racial and ethnic difference in the treatment and outcome in severe aortic stenosis. So, and the key summary and compared to the white individual and the overall use of SAVA and TAVR and black people is much lower, and the mortality is similar, and compared to white population, procedural complication and the length of stay and hospitalization much higher in black person. Also, in evaluating the AS, also treatment AS, there are noted the phenomenon of AS paradox. You know, underrepresentative racial and the ethnic group, the relative to white patient have a higher rate of traditional AS and the risk factor, and such as heart failure, CKD, smoking, and diabetics. By contrast, the paradox whereby underrepresentative group and crossed more AS risk factor, however, show the low burden of the aortic stenosis disease. Look back the current available data, this is the largest registry in TVT registry, and evaluated racial disparity. So, and overall, the black person in the blue and Hispanic in the red and other is black, and the baseline difference was noted in hospital outcome comparison in non-white versus white is no difference. 1 year outcome is the major bleeding much higher in black, and hospitalization was much higher black and Hispanic. However, in Asian data is relatively low. Looking at the TVT registry, less than 3% was Asian population. Recently, we have made a very nice review article published in JACC Asia. I work with Kentaro Hayashida in Japan group. So, and the current available TAVR device in Asian country, mostly commonly used Sapien and Medtronic, also available some the Chinese made available like Venus and the JC valve and the Mitral Life Science. This is available in India. Also, in each country, the availability of the valve type is some different. So, and looking at the baseline clinical and anatomical difference, what is different? What is similar? In age and gender was similar, and the body mass index much higher in Western. Ejection fraction, STS score looks like a similar. Valve area similar, however, annulus area much bigger in Western population. Proportion of a bicuspid valve much higher in Asian population. Device size was higher in the Western population. Looking at the summarized current available national-based large-size registry, key procedural complication, PVL, pacemaker, AKI, any vascular complication. Left panel is Asian population, right panel is Western population. Overall observed instance was comparable. And 30 days, 1 year clinical outcome is based on the available large size the registry, and the left panel is Asian, right panel is Western, and grossly low instance of mortality and 30 days at 1 year and major stroke, but this is indirect observation. Key summary, there is some substantial difference in baseline characteristic. Also, there was observed the procedural complication clinical outcome. Recently, we published in the direct comparison data. This is based on TCTAP registry, multinational, multicenter, multi-ethnic registry published in Heart Journal. TCTAP registry composed of 3 centers, registry in Asa Medical Center, Northwestern Chicago, Stanford in California. 1,400 patients was evaluated, 581 Asian, 831 non-Asian. Looking at the baseline characteristic, body mass index much lower in Asian population compared to non-Asian, mostly Western population. STS score statistically lower in Asian compared to Western population. Atrial fibrillation, peripheral vascular disease much lower in Asian population. Echocardiographic data and the bicuspid valve is much common, and aortic valve area much smaller in Asian population. Looking at the procedural characteristic, as expected, the use of a bigger size valve is much less common in Asian population, and the vascular complication, bleeding complication was much common in the Asian population. So this is observed the Kaplan-Meier curve in the primary composite of death, stroke, rehospitalization, also individual component. This is unadjusted observed outcome. Overall, is all outcome was much less common, lower in Asian population compared to the Western non-Asian population. We conduct several adjusted analyses in the demographic, clinical factor, including echocardiographic parameter and procedural outcome. After aggressive adjustment of several risk factors, there is no difference of all-cause mortality. There is no statistical difference primary composite outcome. It means observed interracial difference in clinical outcome were largely explained by baseline difference in clinical, anatomy, and procedural factor. Key message, even though there are substantial difference of baseline, demographic, clinical, and anatomy characteristics, unadjusted model showing the low instance of all-cause mortality and primary composite outcome in Asian population than in Western population. After adjustment is various and clinical variable, adjusted model, there is no statistical difference. Also, important issue is of prosthesis patients mismatch. We know smaller size valve, smaller size aortic valve area in Asian. So PPM issue particularly relevant in Asian population, unique anatomical feature compared to Western population. This is evaluated in TCTAP registry, published in JACC intervention a couple of months ago. And this study shows the BMI much lower, BSI was much lower in Asian population compared to Western population, but the PPM definition was divided by the effective orifice area divided body surfaces area. By definition, severe PPM much lower in Asian, 7.1% is a 24.7 in Western population. Is the overall instance of PPM was much lower. Also, we evaluated prognostic impact in 1 year outcome, death, stroke, rehospitalization. We didn't find any the prognostic difference in this composite outcome, stratified the race, stratified the presence or absence of the PPM. This is my last slide, summary, interracial disparity in TAVR. Given increased life expectancy in Asian Pacific, the field of TAVR is rapidly expanding. There are substantial interracial differences in clinical, anatomic, and procedural characteristics in TAVR patients. There are specific population and healthcare system related changes to TAVR use in Asia. Finally, future research into racial ethnic disparity can help optimize TAVR procedure in Asian Pacific country. Thank you for your attention.
Thank you very much, Dr. Wu. Excellent presentation. And as we said, we will be discussing the topics in the final round. And the next, also doesn't need any introduction, Vinay Bapat, and he will be talking about transcatheter innovations or transcatheter devices beyond TAVR. Vinny, great to have you. I know you've been back from London. It was kind of a race for you to appear, so we are very grateful that you're with us tonight. Floor is yours.
Thank you very much, Everard. Fantastic talks. Both the talks were, this is a much easier task to follow, really. So transcatheter devices beyond, it's exactly 20 years plus now that TAVR has been introduced in clinical practice, and we all have seen the impact. These are my disclosures. So as a surgeon, when I think about it, what is left? We have addressed aortic stenosis to a point of, it's a common procedure now. There's mitral, tricuspid, of course, and there are heart failure treatments, and there are other ancillary devices which help all these procedures. Mitral, obviously, the treatment revolution started around the same time as TAVR, but we know that mitral valve is more challenging. It's more dynamic. The pathology is very different. It could be primary, secondary, and each of it could have many aspects which are hard to treat with one particular treatment. Treatment of mitral regurg, of course, has been dominated by TEER, or essentially MitraClip, especially after co-op trial. And the main thing what we have seen now is in these patients is not only beneficial, but it's the safety profile of these devices has been huge. And there has been now more and more evidence poured in about the benefits of this particular therapy, and hopefully applied in intermediate risk patients as well, and even in low risk patients at some point. So MitraClip now, variety of iterations have come, and Saibal here on the call. Saibal, you have seen most of these iterations, with the current iteration being G4, multiple advances in terms of single leaflet capture, and of course, different lengths and widths available as well to address various pathologies as well as challenging anatomies. Since the co-op trial and the approval, we have seen explosion of application of MitraClip, and a lot of credit goes to understanding and teaching of imaging, as well as which patients to treat and which patients not to treat. And this has also led to an interesting paradigm in terms of the clip candidates or TEER candidates, which may not get good result. There's a better understanding now, so that we do not try the clip, but do so, or to consider these patients for different treatments. Edwards Life Sciences introduced their version of TEER, and this is a Pascal, which is a class with a filler in the middle. Essentially, this has also been used in mitral tricuspid. The main advantages I hear from users has mainly been versatility of the delivery system, as well as especially in the application on tricuspid area. And we are going to see more of such devices in future. Coming to transcatheter mitral valve replacement, because as I said before, there's a better understanding now of which mitral anatomies may not be suitable for with a good result for TEER. Now we have seen again since 2012 explosion of TMVR devices. Some of them have disappeared and some of them have persevered. The largest experience has been with the Tendyne device, which is manufactured by Abbott, and the Intrepid device, which is manufactured by Medtronic. However, the main focus has now been towards the percutaneous TMVR devices, and surprisingly, there are many more than we all think. So this is the list of percutaneous TMVR devices with first-in-man experience or more than first-in-man experience. This is the device I have more experience with than any other device in this field. This is a two-stent frame device, which is the Intrepid device, the inner frame, which is the functioning frame, which is circular, and the outer frame, which is conformable to the native anatomy. Currently available in two sizes, 40 to 48, but soon to be available in a larger size as well. Essentially started as usual with a transapical device. The generation 2 allows recapturability as well, which has been quite important, although it has only been done in one case up till now. But as we all know now that Apollo trial is ongoing with recruitment, and some parts of the studies have been changed to adapt to the co-op results. Another very interesting group in mitral has been mitral annular calcification, extremely challenging. We know that we had initial experience, a decent size experience with balloon expandable devices as well as repositionable devices such as Lotus. But now, of course, dedicated TMVR devices are being used in this selectively. This is an Intrepid device in MAC. Again, we tend to divide these patients into three groups: prohibitive, intermediate, and favorable. Currently, again, the indication expansion is happening with caution. But Tendyne device by Abbott has really done very well in this because of the anchoring mechanism at the apex. This is one of our patients, again, just to show you how severe the MAC is in this patient who was irradiated before and had a TAVR before. And you can see very beautifully here in the follow-up CT at 3 months and a TE at just proposed procedure that this intraannular anchoring in MAC kind of works very well in these patients. However, one has to still keep in mind that this is a transapical procedure, and these patients in general don't tend to do very well at 1 year and 2 years. The most interesting development has been transeptal. This is the Intrepid transeptal case as the highlight. Very similar delivery system and the delivery of the device through transeptal, open the brim, and then position and deploy. Similarly, there has been now experience with Evoke, probably the next generation device, I would say, again, size 44 and 48, dedicated transeptal delivery system, and they do not do any implants with transapical anymore. This is just to show you one of the cases done by John Webb. You can see again the successful implant with no LVOT obstruction, in particular this patient. Sapien, as we have all used for so many years now, it's natural to explore that platform and see if we can exploit it as a dock and a valve concept. And M3 is exactly that. And you can see what it does is there's a dock which is delivered, a part of it is subannular and part of it in the left atrium. And then a fully covered Sapien 3 valve is implanted in this. And this is exactly how it looks like at the end of the procedure. You can see on the echo on the left side, this is the dock which has been delivered. A part of it you can see in the left atrium. And then essentially it's a valve in a ring procedure. Saphia is another acquisition by Abbott. Again, the advantage of this particular device has been, or at least what we think from the design at present, is the lower profile. And lower profile we know might translate very well into less risk of LVOT obstruction. A lot of the studies in the pig anatomy, which is pretty compact, it has led to no obstruction, so this is very promising. Of course, there are some challenges with this device. Being short, it has to be a very precise delivery. This is again one of the cases, one of our friend Thomas Modine. You can see very nice functioning valve. Ultraval or a 4C is a completely out-of-box concept. This concept essentially, the biggest advantage being there's nothing in the LV, so no risk of LVOT obstruction. Of course, the challenge for particular valve is the delivery and precise positioning, and more importantly, maintaining that position throughout the lifespan of the patient. This is now the transeptal delivery system of this, and you can see one of the successful patients recently done, which I hear is more than 10 now. You can see again a supraannular, so to speak, device, which is 27 millimeters, working like, as they call it, as a chimney mechanism with no risk of LVOT obstruction. Lastly, but not the least, another valve ring concept, high life, essentially a subannular ring only. And this is implanted through transaortic access, that means transfemoral in a retrograde manner, and then deploy the device transeptally. This is one of the cases which Nico Piazza shared with me. You can see a very beautiful result. Again, because of the ring, we believe that this may lead to less risk of LVT obstruction. Coming to the not so forgotten valve now, tricuspid, there have been multiple advances in this, some of course orthotopic and some probably completely out of box. Some of them have fallen through. For example, pharma device, TriLine as I hear now, trial has started in China. Cardiomand is probably making a re-entry. Millipede has disappeared. So multiple new concepts have come, but some of the concepts are making a really good wave, particularly the TriClip and certain TTVR devices. Edge-to-edge, again, this is the first publication in 2017. This has now really evolved into a good science and better understanding. The challenge for this particular device has always been in tricuspid presence of leads. Now, pacing leads can cause around 30% of TRs, which we see in clinical practice, and these are ever challenging to treat. Some of the devices of interest to the audience would be these. Navigate, one of the big advantages, this can be available in a really big profile, a pretty short device. Intrepid device, which I've shown before, same thing, but a slightly different delivery system maybe in future and a larger device. You can also see Evoke, which has been used in mitral, has been, in fact, the largest experience today in tricuspid has been with this particular device with really good results. And a lot of that goes to the delivery system, which allows a beautiful coaxial deployment of this device. And finally, the Lux valve, which is a Chinese valve, again, experience in China as well as Canada has been quite good. As I hear still, this is still a transatrial device, although transfemoral system is coming soon. And finally, but not the least, is the V-Dyne device with the experience of 5 patients. This is supposed to be anatomically conforming device, as one of the biggest challenges in tricuspid has been incidence of pacemaker. And to reduce that, one needs to really allow the less oversizing, so to speak, in tricuspid so that it doesn't impact the conducting system. This device is very unique. It is in terms of, again, an inner valve, and it's a sideways delivery system. And the outer valve or the outer perimeter can be as large as you want, so as high as 180, which is the largest I've seen. The different approaches for tricuspid mainly has been transfemoral. As you know, that a lot of these devices can be large in size, so the main limitation has been the risk of any venous injury. But again, with time and better screening, we are getting wiser. And luckily, with a lot of TR patients, these veins are quite big size. And finally, the biggest debate is in TR patients, especially today, we see them at such far end of the spectrum. Does reduction better than elimination? And then if you are doing a transcatheter valve replacement, some of these questions are unanswered, such as possibility of pacemaker in future. Then you have to go through a new valve. What is the durability of these valves? And finally, anticoagulation. Because many of these patients are not on anticoagulation, like many patients of mitral regurgitation. And this is my last slide. This is to summarize what's been happening in the field. It's not just the valves, but again, there's an explosion of things such as heart failure, as we have seen recently, results from Corvia trial and many other features. Cerebral protection, needless to say, is commonly used in our practice now. Again, many designs came, but this is the one design which has survived. There is an interest in treating aortic regurg and also doing a full root replacement, as we saw the first successful case in Brazil nearly 2 years ago now. And then finally, multiple septal closure devices. Can you close the septum with the large bore catheters and then re-entry again through these septums for different procedures? So we are going to see a lot of new technologies coming in, not only to do the replacements, but for lifetime management of these patients. Thank you very much.
Thank you very much, Vinny. That was brilliant. And there was a race through valvular structural disease with some outlook on new technologies. Very well done. And thanks for keeping the time. SJ, would you like to lead the discussion and start the discussion?
Actually, to the Marie Leon, I really, you are the one of the pioneer of this, and upstream disease you mentioned, including the moderate aortic stenosis by echocardiography. I clearly didn't understand it. All right, would you
I'm
open
muted.
the
Yes.
microphone? All right.
Yes. If you look at the cross-sectional analysis of moderate AS, and if you look at the at-risk features that have been identified, low ejection fraction, symptoms, presence of atrial fibrillation, biomarkers, more than half of the moderate AS patients fall into a category that would be characterized as at risk. So I'm really thinking that we have to consider more broadly, and the severity of the valvular lesion hemodynamically is only part of the problem. And I hope that with future studies, we'll be able to better identify those patients that will benefit from earlier treatment. And many of them will be the moderate AS patients.
So Marty, if I may just come in very quickly, these staging aortic stenosis, obviously, according to your presentation, it's extremely important to detect those patients at an early stage so we don't intervene too late. I mean, we can do this both hemodynamically or echo or markers, but most importantly, in order to this being applied broadly, what would be your vision? Because we cannot do we cannot cath every patient in order to stage the disease correctly. Is there any less invasive procedure or procedures or markers that you can see that will facilitate the staging?
Right now it's more the conventional things that we normally do. It's a transthoracic echo, biomarkers, and by biomarkers I really mean BNP, NT-proBNP, and then a calcium score. Those things really are the major tests that you would need to do to be able to get a reasonably accurate cardiac damage score in a patient. But I'll say that many people think that we're going to be treating too many patients who are too young, and the whole issue of bioprosthetic valve failure is going to be a concern. It turns out that the moderate AS patients on average are about 4 years younger than the severe AS patients. So they're a little bit younger, but not that much younger. Second point is, I do believe that we're going to have more and more of an effort to be able to prolong bioprosthetic valve life with a variety of new leaflet technologies that we'll be seeing over the next several years. So I'm encouraged that these will move in parallel. There'll be better pharmacotherapy, there'll be improved leaflet durability, and there'll be better staging and identification of the at-risk patients, so that over the next decade, we'll have a good understanding of how we can better optimize treatment. It is frustrating in a cross-sectional analysis of all TAVR patients that at 1 year, 50% are either dead, have had a heart failure hospitalization, or have had no improvement in their KCCQ score. We have to be able to do better than that. And I think a lot of it has to do with delayed treatment.
Great.
Thank you.
So I have also a question for Dr. Leon. So don't you think that a low event rate that you would expect in trials like those in patients with moderate aortic valve stenosis would be a challenge to find a meaningful difference in clinical endpoints?
I think these studies are not going to be easy. I think that moderate AS is a different disease. Many of these have low flow, low gradient AS. Many of them have discordant diagnoses where you can see a low gradient, but yet the peak velocity is not within range. So the accurate diagnosis of moderate AS is much more subtle than severe AS. But I do think that there is a significant population. And in the first cross-sectional study that we did with Nick Van Meegen, which has been extended further, looking at the moderate AS patients with reduced ejection fraction, their outcome without treatment was absolutely terrible. Mortality, heart failure, hospitalizations. So that group in particular really deserves to have a consideration for earlier treatment. But these will not be easy studies, Tulio. And it's going to still take several years for us to have enough sufficient data to justify moving in this direction.
Any comment?
So, Marty, I mean, more simplified by the staging system of the ACC, where you divide valvular heart disease to A, B, then C1, C2, and then D, right? And more we believe that, according to you, that should we start treating patients with C1 disease, C1 being defined as asymptomatic but severe disease, or of course, moderate disease. So and this is becoming a paradigm regarding with mitral valve repair. Surgeons are considering mitral valve repair at early stage. When it comes to aortic valve replacement, the biggest concern I have is, does the natural history of the disease, is it worse than the natural history of the valve? Because when you put these valves in, these biological valves in, they are actually going to deteriorate. They don't have perfect hemodynamic profiles. When you put a sapien valve or any valve, you get a gradient around 10 to 15. Now you start treating patients with moderate AS, and then they come back with gradients of 12, and they started with 15. Have you really done a good thing for the patient?
No, it's a very good question. I mean, obviously, you have to look carefully to be certain that the valve that you're implanting is going to result in better hemodynamics than the disease that you're treating. So there's no question when you're dealing with moderate AS that you do have to be very sensitive to valve size, to what the residual gradient is before you implant, and what the expectations that you're going to be able to achieve in terms of the valve size that you can use to be able to achieve a better hemodynamic result. The other thing that that's become obvious to us, at least in some of these studies, a good example is the early TAVR trial, where again, we've enrolled now 900 patients. And those patients that are in active surveillance, the number of patients that progress with symptoms or with hemodynamic burden or with unplanned hospitalizations was shockingly high. These are exercise-proven, asymptomatic, severe AS patients. Within 1 year, 30% of patients had already crossed over, which suggests, and that requires that you be meticulously following these patients. And as you well know, symptoms are not precise, especially in an elderly population. So we're going to learn a lot from the early TAVR trial. And I think that, people have a misguided sense as to the rapidity of disease progression and the relationship of symptoms to ultimate outcomes. There are many other things that I think are greater at-risk features that need to be considered.
So, Marty, I'm sorry to just ask one more question. To that point, if you're taking severe aortic stenosis, you go through a spectrum, as you said, from being asymptomatic to symptomatic, right? So that's okay. That means so that shows that the progression of disease. My concern is moderate aortic stenosis. If you take a patient with moderate aortic stenosis, how often does that progress to become symptomatic and severe?
We don't know with certainty because the natural history studies aren't perfect. Probably the best studies are the longitudinal studies that are done in large clinics, and Jerome Bax in Leiden has a very large population, and we've actually been looking at that. And there are fast progressors and there are slow progressors, and moderate AS is a range. I mean, many of these, as you know, a valve area of 1.1 is moderate AS, but still, these
or
patients
body surface area could be severe.
So, it certainly could be severe. There's a continuum in terms of valve severity and associated cardiac damage. They both need to be evaluated in terms of making what I hope will be the best decision for earlier treatment.
So Vinny, if I may ask, coming back to your presentation, which was really brilliant, because you gave us an idea of what we have done in the past and what we have to expect. You know, what is your thought process if you look at all the effort in valve replacement in mitral? What you know, are we staying with the extreme or high risk group, and will we ever be able to get down into low risk areas where the competition and you know, the competitive situation with surgery will become much more important? Do you see this happening in the near or midterm future?
It's already happening in the US for sure, with 2 trials currently proposed, and will be one running and one upcoming. The repair and primary trial, where TEER device will be tried in one trial in intermediate risk patients and another trial in all comers. Surgeons are engaged in this as usual. There is in general a fear that where is this going in terms of not just surgery, but in the longitudinal you know, follow-up of the patient or lifetime management of the patient. I think these trials are critical because they are going to show us, you know, what we do, you know, finally is beneficial long-term or not. If you look at even mitral surgical trials, not trials, even I would say experiences, they are generally from one center to a limited follow-up. So I think these studies are critical. As far as TMVR is concerned, there's probably less hesitation among surgeons. And for tricuspid, I would say there is no hesitation among surgeons, because most of the isolated tricuspids are rarely operated, or they're operated in less numbers. In concomitant tricuspid, there is there's a massive increase in surgical repairs in concomitant tricuspids. And I think we need, as surgeons and surgical industry, to make an effort to, for example, design surgical rings which are suitable for future transcatheter treatments. Currently, at present at least, I don't see any effort on that side. So it's a very interesting, in some areas, surgeons are probably less engaged, but in other areas, my generation mainly is extremely engaged and looking at, even if we do surgery, how we can do surgery with understanding of what is the impact on the patient in lifetime. The last thing we want to do is, say, do a repair badly, which fails, which relegates a patient to second surgery or something else, or at the same time support a transcatheter treatment, which looks good for 2 years, but then relegates a patient for a replacement after that. So these are unanswered questions amongst my community.
Dr. Finkelstein, is there any other comment on that?
Yeah, I got to go back to Marty. Winnie, I'm sorry, but I got to go back to you, Marty. I got this deja vu with the coronaries. You know, at the beginning days of the stents, we didn't, you know, proximal LED was a surgical disease until we had the drug-eluting stents. So I think that don't you think that before moving to moderate aortic stenosis or asymptomatic aortic stenosis patients, we need a drug-eluting valve, so-called, or namely a truly much longer expectancy of patency of these valves?
I mean, obviously, we would all like a one valve for life. And I think there are some interesting concepts being developed. And, you know, I think over the next many years, we will have more durable valves. I will say right now, and, you know, Lars is on the line, you know, he's got the longest follow-up of randomized trial with serial echoes. And even the current valves are doing pretty well. They're doing at least as well as surgery. Mm-hmm. So I think that I don't think that we really give up very much with the current version of bioprosthetic valves compared to surgery. But I realize when you put a valve in, you're introducing a new iatrogenic disease, and you've got to be sensitive to that. I'm particularly concerned about the younger patients when we're talking about the potential of serial treatment. But earlier treatment doesn't necessarily mean very much younger patients. As I said, the mean age of the moderate AS patients that were in the Australia ECHO database was 74. So these are still relatively elderly patients. And I think if you're selective in terms of who you choose, I still think that it will be very justifiable to go ahead with earlier treatment in some of these moderate AS patients.
Back and while you were presenting this, and we know that moderate aortic stenosis is not a benign disease, as you pointed out, given the midterm mortality, we're moving in a pace that's, considering the long-term history of aortic stenosis, incredibly fast, because we're gaining a lot of experience and new insight, because all these studies have been very successful. That is a challenge if we go to the mitral and tricuspid field, where we move a lot slower. We need more understanding of the disease entity. And then not only is the disease on the mitral side with primary, secondary different, but then there's a difference between mitral and tricuspid. How do you see, and looking at from a physician standpoint, not necessarily innovator standpoint, from a physician standpoint, do you think we will, in the near or midterm future, taking the clip, for example, for now, a little bit to the side, do you see that we were able to speed up the development in the mitral and the tricuspid field, not to compare it with aorta, but that we can move a little bit faster? Or do you think this is going to be a long, slow race?
Well, it's already been a long, slow race. Remember, the Everest 2 trial began before the PARTNER trial.
Right.
And if you look at the number of randomized trials in primary MR, there haven't been very many. And the ones that have been completed have largely been outdated with new technology. So we need to study more patients. We need to get better experience. I don't frankly believe a lot of the surgical data suggesting that primary MR repair in a large number of centers is going to get the kind of results that some of the major academic and other centers are able to achieve with high volume experiences. So I think both the surgical data needs to be more carefully looked at. And I think that the MitraClip, the TEER results are getting better and better. So I would like to see comparative trials where we have larger numbers of patients in different populations that are looked at in a very carefully controlled way, correlating the reduction in MR severity with clinical outcomes, including quality of life. And that's really what we're trying to do. Accumulate more data so that we have a better understanding about whether or not the patient population can be expanded beyond what is currently the approval indication, which is prohibitive or high risk only.
The question about what kind of patients treating. I mean, it's a complex decision to make expansion of the indication for aortic valve replacement. It's going to be what's the benefit to intervene early on, and also what's the risk of doing it. And going to patients with longer life expectancy to implant these valves at an earlier age is going to also be associated with what's the risk of that. Permanent pacemaker, access to the coronary arteries. What about when these bioprosthetic aortic valve is going to fail? What is the options for re-intervention? So I think we need more evidence before we can actually justify to do it. And I think short-term outcome as 1 or 2 years outcome is not going to be sufficient for that.
Yeah, I think that's a very good point, Lars. I think that the longer-term outcomes, these studies are going to run for 10 years. The primary endpoint is going to be earlier, but these studies are really conditioned to running for a full decade. And I mean, obviously, we'll follow them even longer. So I completely agree. We need to get much more evidence before we advocate any of this. And it's not so easy to enroll patients in these clinical trials because the control arm is active surveillance, and it's very difficult, frankly, to get patients to agree to some of these newer studies in untested indications. But it's the only way for us to learn. Just like you're doing a study in younger patients. We need to have these data. We need to get more data in younger patients, Lars, to know whether or not a lot of these concerns with respect to therapy sequencing and a transcatheter valve failure is really going to be, as much of a problem as many people, have predicted.
So,
Okay, all right. I have a simple, question. The PPM matters. Actually, you show that it's not a big deal in TAVR, especially in Asian patient. And could you tell us why? Could you tell us, why the difference would be, and if you can tell us about the compare with the SAVR, so we have a little bit different, concept.
yeah, yeah. I think the PPM definition still the controversial and arbitrary. The PPM definition is now sometimes criticized by the racial fallacy. Although the PPM is defined the effective orifice area and divided by body surfaces area. So, and the reason why in the theoretically the East Asian population is a smaller size of annulus and valve size, and the initial gas and the PPM could be much problematic in Asian population compared to Western population. But observe the thing, PPM, the severe form is much lower in the Asian population. There is some criticized PPM definition is a racial fallacy. So I think we need the require further data to define the real PPM problem. Also, we require more data is PPM, how in fact durability of a TAVR, or how could we use the risk stratification. We need more data, absolutely.
All right, Evad, would you close this session? I'd like to thank you all for really, good session, make a good session here. So it was close there.
I will participants for excellent presentations. We've learned a lot. We covered the field of valvular heart disease and of racial disparities in different geographies. It was very entertaining, very insightful, very informative. And I thank the audience for their attendance. And I hope at some point, hopefully next year, we want to be able to see each other in person in Seoul. SJ, thanks very much for having us again. And good luck, and thank you for the ones that are staying out late and the ones that are getting up early. We're in different time zones. There's an advantage, but I hope that at some point we will be in the same time zone and discuss things and meet friends again. So thank you very much. And with that, SJ, I think we conclude the session, and thank you to the presenters and the audience for their attention.
Thank you. Good night.
Thank you.
Thank you very much.
Thank you. Thank you. Bye.